everybody into the room and then we will get started. Thank you so much for your patience. Hello, everyone. Thank you for joining us. We're just going to give Zoom a few more moments to add people into the room and then we'll get started. Thank you. Hello, everyone. I anticipate people will continue to join, but we will go ahead and get started as we have a lot to get through. Thank you, everyone, for joining us. I'm Gregory Phillips with Duke Communications. Welcome to the latest Duke media briefing on reproductive health care. The North Carolina State House on Wednesday approved a ban on most abortions after 12 weeks of pregnancy. The Senate is currently debating the bill and is expected to vote on it today. And while Governor Roy Cooper said he will veto it if passed, Republican supermajorities in both chambers means any veto could well be overridden and the bill would become state law. We have three Duke experts with us today to discuss the potential impact of this law on reproductive health care in North Carolina. With us today is Dr. Beverly Gray. She is Division Chief of Women's Community and Population Health at Duke and founder of the Duke Reproductive Health Equity and Advocacy Mobilization Team. Also joining us is Dr. Jonas Swartz. He is Director of Family Planning in the Department of Obstetrics and Gynecology at Duke and a researcher in reproductive health equity issues. And we have Jolyn Dellinger. She is a visiting lecturer at Duke Law School and a senior fellow at the Keenan Institute for Ethics at Duke, where she teaches ethics, privacy law, and policy. Good afternoon to you all. Dr. Gray, we'll start with you. What are some of the difficulties that a 12-week ban would create in providing reproductive health care to your patients?
So this legislation that is being actively discussed right now in the Senate, we have a lot of concerns about many factors that are included in this bill. But limiting care at 12 weeks, that's an arbitrary cutoff line. And we know that in states that have strict abortion bans, including bans like a ban at 12 weeks, it impacts care for patients who need care after that period of time. And there's so many things that are unclear in this legislation as it's written. It will make it very challenging for healthcare providers to interpret it, to understand who will merit care after 12 weeks, who won't. There are many scenarios where patients need care after 12 weeks. Some of them receive devastating news of a birth defect, or at that point in pregnancy, sometimes patients have medical complications. And we talk about this a lot. Being pregnant is very much like running a marathon, and it's hard on your body, especially if you have underlying medical conditions like high blood pressure, diabetes, heart disease, kidney disease. And when you get to that point in pregnancy, some women get sick, but it's unclear in this legislation who is sick enough for us to care for. And that makes it very challenging to be able to do our jobs effectively, to counsel patients on evidence-based practice, and to just, be able to care for patients with compassion, with knowledge, with science. It limits all of that.
Absolutely. Thank you. So much to dig into there, and we will get to that. But Dr. Swartz, I'd like to move over to you. Although this bill would allow for abortions up to 12 weeks into pregnancy, what effect would it have on access to that care for patients who do want a legal abortion?
Yeah, so there's a couple big red flags or problems with this legislation. So one of the big things is that they have increased the administrative burden of providing abortion care to an almost untenable level. Currently in the state, we do have a 72-hour waiting period, which is cumbersome for patients. But fortunately, the initial counseling right now can take place over the phone, that state mandated counseling. And this would require 2 visits with the health center for the individual. And so that means that people would have to get childcare, take off work for an additional day for a completely unnecessary visit to get state mandated counseling. In my time practicing in North Carolina, that state mandated counseling that we provide 72 hours prior to the abortion, we do it every time, and it has been helpful 0 times. We provide informed counseling and get informed consent from our patients as a component of medical care. So the idea that they need to have this counseling in person simply is creating administrative hurdles and making it more difficult for people to get abortion care. That's just one of the administrative burdens that they placed on care. I mean, the other big thing to think about is that care will be limited at 12 weeks. And so that means that there are many people who are going to be needing to leave the state for care. We safely provide care in outpatient settings across the state right now between 12 and 20 weeks. And this bill limits care after 12 weeks to hospitals. That provision is completely counter any evidence on the safety and quality of abortion, which shows that abortion is safe up through the second trimester in outpatient centers. So this law doesn't use evidence-based medicine, doesn't allow us to practice evidence-based medicine, and will restrict care to the point that it's going to be really difficult for us to care for our patients.
Absolutely. Thank you very much, Dr. Swartz. And again, an awful lot to dig into there as well. But Professor Dellinger would like to come across to you at this point. This law does criminalize most abortions after 12 weeks. But what does it say about who can be prosecuted and when, and why is that important?
Well, I would reiterate the comments that clarity is a huge issue here and a huge problem. So it is unclear who can be prosecuted under this law. It's unclear when a physician can act in a medical emergency. It's unclear how physicians can comply with these administrative requirements. But the first topic is the one that I would touch on in response to your question, which is that it's unclear whether women in particular can be prosecuted for self-managed abortion. And it's the law purports to repeal section 45.1 and replace it, but that leaves in place sections 1444 and 1445, which make the provision of abortion a felony. So I think sometimes when we're talking about, oh, there's a 12-week limitation on abortion, we're losing sight of the bigger picture that if an abortion is not lawful, an abortion can be considered a felony. So doctors going to work every day are deciding whether or not they might be engaged in conduct that is a felony under state law. So the reason that it's important for women is this new law says all lawful abortions must be performed by qualified physicians. So if you're a woman and you can't get access to care for a variety of reasons, and you go online and you order medication abortion from Plan C or Aid Access, and you give this medication to yourself, that appears to be not a lawful abortion under this law. Can a woman be prosecuted for self-managed abortion? And if the answer is no, then the legislature needs to be very clear about that in this law. So there are two provisions in here that do that affect the prosecution of women. One of them says no pregnant woman seeking to obtain an abortion in accordance with this article shall be subject to professional discipline for attempting to do so. I have literally no idea what that means, just throwing it out there. And then there's another section, which is in the part about infants that are born alive. And it does say the mother of a child born alive may not be prosecuted for a violation of that provision. That does not speak to whether women can be prosecuted for self-managing abortion. Why is this important? Again, because the more administrative regulations that are layered on, as exactly what this bill is doing, the less able providers in our state are going to be able to fill the needs of people who need care. And abortion restrictions don't stop abortion from happening. People will just order drugs online, get drugs where they have to get drugs, go out of state. Abortions are going to happen. So the legislature, again, needs to be very clear when we are talking about making abortion a felony. Who are we talking about? Who are they going to prosecute for these alleged crimes?
Absolutely. Thank you, Professor Dellinger. Thank you to all three of the panelists for those opening answers. There's certainly more here than we can get to in an hour, but we will do everything we can. We're opening up to questions. If you would like to pose questions via the Q&A window, you can do so at any time. We have questions submitted in advance that we will try to get to. To start off with, Dr. Swartz, I'd like to come back to you. The new law, the new bill, presuming it becomes law, has this new 2 in-person visit requirement prior to getting an abortion. Can you talk about whether there is any medical justification for that, or what the purpose of it would be?
Yeah. I think that when people seek medical care, they want to have a compassionate practitioner who they can sit down with and perhaps help them make the decision, or decide what's best for them, go through their options. This provision, this 2-visit provision, does nothing to facilitate that. In fact, what it seems to suggest is that a patient would have to come in for the 72-hour counseling, the state mandated counseling, at least 72 hours prior to initiating the abortion. I feel like there's a lack of clarity about whether the pregnant person has to have an ultrasound at that juncture. And then there's also a requirement that seems to suggest that the person has to have another ultrasound, potentially a second ultrasound, 4 hours prior to the abortion procedure. These sorts of details really matter in terms of how we provide care, right? I can't really come up with a scenario where it makes sense to provide care with all of the sort of administrative hurdles they've put in place. So I don't know how we're going to navigate that as clinics. I don't know how patients are going to navigate that. Essentially, it just makes people waste tons of time in accessing the medical care that they have decided is best for them. When patients call our clinic, they have already thought about their decision to have an abortion for a long time, and generally they've come to that decision. We do, just being good doctors, review their options, make sure that it's right for them, make sure that it's not being that they are not being coerced. But this law does nothing to help us with that process, and it creates a false narrative that doctors are the ones pressuring patients into having abortion care or not offering them alternatives. That just is, it's insulting. That's not the way we care for patients. And that's not, but it does create this false narrative about the sort of medical care that people get in clinics that provide abortion. And it's just not true.
I'd like to come back to you. We know that most abortions in this state take place before 12 weeks, but there are lots of examples of abortions that take place after 12 weeks that this law would preclude. Can you talk a little bit about the kind of circumstances that require an abortion after 12 weeks of pregnancy?
So we know that most abortions happen in the first trimester, and the care of those patients will be affected by this ban and the exact restrictions that Dr. Swartz was talking about. So for patients who are past 12 weeks, those patients may have received a recent diagnosis of a genetic abnormality, of a birth defect on their ultrasound. So patients typically will undergo the ultrasound to review the anatomy, and often around 18 weeks. And often people think of this as like the ultrasound where you might find out the sex of the baby. And for a lot of people, it's a very happy, exciting time. And for other patients, they find out a devastating diagnosis. And then they need to maybe get further testing, talk to other specialists before they make a decision. And it's unclear in this bill who will be able to receive care if they receive a diagnosis of a birth defect. And so that we're unsure who will be able to care for. There are other patients who maybe live in a rural part of the state and don't have access to care. There are many parts of our state that are maternity care deserts. So they may have had to wait to get an appointment to find out how far along they are. Maybe they have irregular periods. Maybe they're a teenager and they have irregular periods or just don't understand their bodies yet. And so they're more likely to present later in pregnancy. Patients living in poverty are more likely to present later in pregnancy. And so these are patients who who will be immediately impacted by this ban. And for patients who can't afford care, they may have been delaying care to be able to pay for care. And so that pushes them further into pregnancy. And for many of those people, the administrative burden, all of the appointments, all of these other hoops they need to jump through may be impossible for them to get care in North Carolina. And it may be impossible for them to get care outside of our state as well. And they will be forced to continue their pregnancy. Now, you may have been hearing legislators saying that they've talked to doctors about this legislation. And yes, we have tried to talk to as many legislators as will listen to us. And many of them just flat out would not talk to us about what we had to say about medicine, about evidence-based care, about the scenarios that we see every single day. Now, some of them were, but many of them were not. And some of them were saying, well, I only want to talk to an OBGYN who lives in my district. Well, if you live in a rural district in North Carolina, it's very likely you live in a maternity care desert, which means there may not be an OBGYN in your county that could talk to your legislator. So they closed the doors to us, to many of us. And so the other false narrative that we want to talk about is that they're not listening to doctors that provide this care. And in North Carolina, there are 91 counties where there is no provider of abortion care. So patients have to travel. And so these, all of these hoops that people have to jump through to go to 2 or 3 visits to complete their care, it's unnecessary. And for patients that live in rural North Carolina, it's just going to be impossible.
Back to you. You touched on this briefly in your opening, but this bill appears to include text from several prior abortion bills, including some that have been blocked by federal courts. What can you say about how repassing block legislation is or is not permissible, and how it could be viewed by the courts?
Sure. So one of the provisions that we were talking about earlier in the day in our conversations was the real-time view requirement that was apparently included in earlier legislation. And the Fourth Circuit said that North Carolina's provision around this real-time view provision and the language, the requirement that doctors had to narrate in real time an ultrasound for a person seeking an abortion was a violation of their First Amendment rights. And there is a circuit split on this. I think the Fifth and the Eighth Circuits have come to different conclusions than the Fourth Circuit did. And I believe the Supreme Court decided not to hear that case on appeal from the Fourth Circuit. So it seems like even though that has been language that has not been enforceable recently, now after Dobbs, it seems like they're just putting that language back in there and maybe seeing what's going to work. And maybe they would get a different result. Maybe this Supreme Court, if it got that far, would resolve this issue in a different way. And I think that what we also may see is during Roe and during Casey, there were any number of decisions that said a variety of things were undue burdens on a woman's ability to get an abortion. Well, Dobbs overruled Roe and Casey. So all of those things are kind of out the window. So there may be cases out there where a court said this or that is an undue burden, but it seems like legislatures generally are going to take the chance of putting those things back in. Now, of course, some states are just banning abortion flat out, right? Just criminalizing it altogether. Tennessee is one example of that. But in a state like North Carolina, where you're trying to say, okay, some abortions are okay, and others are not after 12 weeks and under these circumstances, you still are going to lead in the whole process down with all of these restrictions, which maybe in a previous era, we would have considered them undue burdens, but now we don't have that argument to make. So I think that's going to be tough.
back to you. Can you say, Dr. Gray talked about that some lawmakers didn't seem to want to hear from doctors on this. What are medical societies saying about this particular bill?
Yeah, as Dr. Gray mentioned, our medical societies have been vocal in opposition to this bill. The North Carolina Medical Society issued a renewed reproductive health access policy, which was very supportive of abortion and opposed legislative interference in the doctor-patient relationship. The North Carolina OBGYN Society supports the policy of the American College of Obstetricians and Gynecologists, so is supportive of abortion care. The American Medical Association is supportive of abortion care. The World Health Organization is supportive of abortion care. And in the past couple of days, both the North Carolina Medical Society and the North Carolina OBGYN Society have issued statements specifically opposing this bill. Additionally, there is an open letter which over 1,400 healthcare providers across the state have signed in opposition to bans on abortion in North Carolina. So the legislators simply are not listening, who are pushing this legislation are simply not listening to the medical community or listening to the people who their patients trust to help them make decisions and to help them get medical care.
Absolutely. Thank you, Dr. Swartz. Dr. Gray, I'd like to come back to you. You mentioned in your last comments about the exception in this law for fetal abnormalities, but it mentions that the language is life-limiting. And how is that legally defined? Is it medically defined? And how much leeway does that give you in working with patients on determining whether to continue with a pregnancy?
I mean, that's not a term that we use in medicine. I mean, I think it's hard to define what is life limiting, and then how will those enforcing the law determine what's life limiting. It's incredibly unclear. And so physicians and hospitals will have to interpret that language. I mean, if this bill had gone through the typical process where it was heard in committee and, people had an opportunity to give public comment or ask for clarity, or, just the medical society could have reviewed the bill and given feedback, but none of that happened. And so there are many flaws in this legislation, including the lack of clarity and how it will be interpreted. And so it just creates chaos. It creates chaos for providers, and they have to determine how they will move forward and how they will care for people, and determine who will be able to receive care in our state.
Back to you, just as there's this vagueness around what life limiting means, there are exceptions in this law for when the health of the mother is at risk, but it talks about reasonable medical judgment as to whether a pregnant patient's life is in danger. How much reassurance does that give you that you can make medical decisions, without potentially getting into legal jeopardy when you're trying to protect a patient? And what is the problem with kind of not defining what actually constitutes a life-threatening condition for a pregnant patient?
Yeah, so that's a really important point, that the maternal health exemption is actually quite narrow and is borrowed from the past legislation that delineated when we were able to provide care in a medical emergency over 20 weeks. And so now that it applies that to maternal health conditions that may arise also between 12 and 20 weeks. In the past couple of weeks, I have cared for a number of people who had cardiac conditions, actually, which would mean that their risk of mortality in pregnancy was exceedingly high, from 25 to 50%. Those are people for whom pregnancy may be contraindicated. We wouldn't recommend pregnancy, and who doctors, after consideration of the patient's values, may say, to save your own life, abortion is the right choice. Notably, however, several of those women who I've cared for have been in a situation where they were healthy at the time they were getting abortion care. And so if someone presents at 13 weeks, has a condition which we expect to deteriorate and would expect would be a contraindication to pregnancy, but is not currently ill, can we provide care under this law, or do we have to wait for them to get sick? The maternal health exemption just is not broad enough. Senator Kravich actually said that she felt that provision specifically needed to be updated in the old law because it was archaic, but they carbon copied that language from the old legislation. So they failed in her goal. She's one of the sponsors with this legislation. And my concern is that now, so what's going to be the process to care for these patients with health issues between 12 and 20 weeks? The body doesn't know that you are now 12 weeks pregnant and there's an abortion ban, so it can't get sick anymore. No, there are progressive issues, as Dr. Gray was saying, that can get worse in pregnancy, including between that 12 and 20 week mark. And so what level of health risk do they need to rise to for us to be able to decide that we can move forward with an abortion? This bill places a burden of providing care ancillary to abortion care on a number of different doctors who maybe haven't encountered that before. So we were talking about the exemption for fetal health. Well, doctors are now, the patient will have to sign an attestation that she was offered a consultation with a neonatal care provider as well as a palliative care provider. Well, how are we going to get those people to in the loop so they can easily see patients, feel comfortable providing adequate documentation? I think that the point of this legislation is to make people scared of providing care. And so these colleagues of ours who we currently ask to see patients when it's necessary will now have that fear of providing care. Am I doing the right documentation? Am I going to be punished? Am I going to get a fine? Am I going to be committing a felony? And there are several additional providers, which we can talk about later, who now will be called upon to provide this documentation, which is poorly stipulated in the bill. But the overall effect is it's just going to have a chilling effect on care. It's going to make it that North Carolinians have worse healthcare, and specifically North Carolina women have worse healthcare.
The bill is currently being debated by the Senate, but it was written without public input. It was hurried through the House without public hearings of any kind. Can you talk a little bit about why that's significant for such an important change in the law and what is lost when that doesn't happen?
Yes, definitely. One thing I do want to just follow up on Dr. Swartz's comment about the reasonable medical judgment in your question there. Just in terms of clarity, a medical emergency definition in this bill says a condition which, in reasonable medical judgment, so complicates the medical condition, et cetera. So that's really wiggly, right? And I would like to just throw out that if North Carolina legislators trusted doctors and trusted women, the language could be different. The language could say any decision about a medical emergency could be entrusted to the medical judgment of the treating physician using an evidence-based standard of care, entrusted to the judgment of the physician. Full stop, we're done there. So that's something that they could try to do, as opposed to putting language in there that allows them the opportunity to second guess at a later time, perhaps in a prosecution, whether or not it was reasonable medical judgment to that extent. So the other point, and Dr. Gray mentioned this before too, this thing has just been whipped up in behind the scenes, right? And there have not been public hearings. There hasn't been testimony for experts. And this is an incredibly complicated topic. Moreover, it's a topic where, we're not the first people to this party. There are 13 states that have criminalized abortion already. Right? So we can have the model of what other states have done and how devastating the consequences have been that some of those choices represented in those state laws. So we could have had an actual process where we have experts go in and really talk to the legislators about, okay, we understand this is what you're trying to accomplish. Here's what doesn't work. Because we have these examples that are out there. And the failure to have any kind of expert input, the failure to have hearings, the failure to take this slow and make sure that they get it right is just another example of the erosion of the democratic process that we're seeing all over the place. So we're also seeing across the country, Republicans undertaking measures to to stymie the democratic process in other ways, like changing rules about ballot initiatives, right? Ballot initiatives are actually a really, really efficient and good way in states that permit that to get a resolution on this abortion thing. You put the abortion, one issue, you take care of it, you know what the population thinks. We don't have that option here, but the states that do, they're trying to make it be a 60% vote of a ballot initiative instead of just a majority vote. So the idea that this was all supposed to be returned to the people and their elected representatives, and this, bandying about of the democratic process is just strange, when at every turn, these individuals and groups and parties in the anti-abortion movement are undermining the democratic process. Another example is forum shopping for Judge Kaczmarek in the middle of Texas to take this action to try to outlaw mifepristone for the entire country. Again, not really part of the democratic process. So I hate to see North Carolina jump on that bandwagon. I've lived here my whole life. I had higher expectations.
Submitted ahead of this briefing that I'd like to get through. Dr. Gray, I'd like to come back to you. One of the questions is, can you talk about how often third trimester abortions actually happen and under what circumstances?
North Carolina, they don't happen at all. So I think this is a false, we can do some myth busting here, Greg, and say that third trimester abortions are a myth. And I think it's a favorite talking point of the anti-abortion coalition, but it is not. I've been in medicine over a decade. I've been, working in OBGYN, and that's not something we need to legislate against, because it's not something that happens. What's happened over my time in this last decade is that North Carolina has become a progressively more hostile state with respect to provision of abortion care. And so we have a 20-week ban. We have bans on who can provide care. We have bans on medication abortion. We have all kinds of legislation that interferes with the practice of medicine. And I think it's not a question. I mean, it's a waste of time talking about it, because it's not a problem that needs to be legislated. And so I think it's very frustrating to hear that brought up, because we already have a 20-week ban. And I think for people who think that the 12-week ban is going to prevent third trimester abortions, they don't happen. So yeah, I think you can maybe detect a little bit of my frustration about that, about that question. But I think, again, there's just a lot of misinformation that's out there, and just kind of a lack of willingness to understand the perspective of patients, the perspective of doctors who are providing this care. I would say, the patients that we care for are sometimes facing really challenging life circumstances, and it's a privilege to care for them and to be a part of their lives at a time where they need our help. And I think the way this law is written is very disrespectful towards physicians, with this assertion that we don't provide informed consent, that we're not talking with patients about their options. That's what we do all day long. I mean, we agreed to the Hippocratic Oath. We are people of sound morals that want the best for our patients and for their families.
Absolutely. Thank you very much, Dr. Gray. I can appreciate your frustration, and I appreciate you sharing those thoughts with us. Another question that I'll direct to you, Dr. Swartz, asks, are there any other medical procedures you know of that require by statute written consent in person, a specific waiting period, again dictated by state statute, and that must expire before the procedure can take place, and a follow-up appointment required by statute? Are there any other medical procedures that require anything like this?
I cannot think of any other medical procedure that has even close to this level of regulation. And it's ironic because abortion is one of the safest procedures we provide in medicine. The National Academy of Sciences, Engineering, and Medicine has an excellent systematic review from 2018, which concluded that abortion is safe and that the sorts of regulations being considered by the North Carolina legislature do nothing to make abortion safer. They only make it more difficult to access. So it's a great question. I can't think of another procedure, even procedures that are much, much more dangerous than abortion. So this is just unnecessary and burdensome regulation.
Absolutely. Thank you very much for adding some clarity to that. Professor Dellinger, would like to come back to you. It seems that if this bill were to become law, it will almost certainly be challenged in the courts. Do you see any parts of the law in particular that you would expect any opponents of it to target in legal challenges?
I think primarily what we discussed earlier. I think if you are if you're looking at, for example, the provisions about the real-time view and the forced narration by the physician during an ultrasound, I think that's a problem. There are some interesting provisions about advertising. There's one section that's called providing or advertising abortion-inducing drugs to pregnant women. And one thing that I would note about that first section is that it's pretty broad. It says for any individual within the state to mail, provide, or supply an abortion-inducing drug directly to a pregnant woman in violation of the statute is a problem. It's a $5,000 per violation fine. So that conduct, I do think, could come within the meaning of 44 or 45 and be a felony, but also it could be here. Imagine if you are a parent and you got abortion drugs for your child, or a friend and you got them for your sister, or the father of a child and got them for a partner. It seems that it could come within that phrasing. But then anyway, the third provision in here says that any individual or organization that purchases or otherwise procures an advertisement, somebody who hosts or maintains a website or provides an internet service that's directed to pregnant North Carolina residents, this is unlawful if it is solely to promote the sale of an abortion-inducing drug to be administered to a woman. So I'm not exactly sure how, I think that raises some significant First Amendment issues. I think it would be challenged. I'm not sure how it would be enforced. But I can see somebody having something to say about that, because there are certainly entities that are doing that very thing as we speak.
Absolutely. Thank you very much, Professor Dellinger. Another question's come in. Dr. Gray, I'd like to direct this to you. We've talked a little bit about exceptions, and there is an exception in the law for cases of rape and incest. But what would it mean in a case in which that information didn't come to light until past the cutoff date? Is this something that happens, and how might that impact doctor and patient decision making?
Right. I think, we unfortunately care for patients who have been victims of sexual violence, of incest, of rape, and sometimes we care for adolescents that have experienced these tragic things that no child should ever have to experience. And sometimes those children don't understand their bodies. Some haven't even started their first period yet. And they may find themselves pregnant at a later time. And you can imagine that for a child that doesn't understand their body, they might find themselves further along in their pregnancy. There's some question around, what sort of reporting do those folks have to do? And maybe Dr. Dellinger can talk about this a little bit more, but it's, it could create issues for reporting. And I think for some of these teenagers or other folks, it can be, their lives could be potentially put in danger with some of the reporting requirements. So I think there's so many circumstances I could imagine where, we don't meet the exact rules of the 20 weeks. And I would say that category of patients, especially adolescents who are victims of sexual violence, they tend to present later in pregnancy. And so then you're kind of rushing to kind of meet all those requirements to get them care.
Come back to you, Dr. Swartz. In 2020, you led research that found many people have little knowledge of abortion laws and that also and tend to perpetuate myths about the procedure. Given the limits on reproductive health care that this law would impose in this state, how concerned are you that the misinformation that already exists and the myths that get perpetuated will further complicate people seeking what will remain legal care in the early stages of pregnancy?
Yeah, what we found was that a minority of people had good knowledge, high levels of knowledge of their state's abortion laws, and the current legal environment with this patchwork of laws across the United States and various bans, various restrictions means that it's all the more confusing to find care in your own state, or if you can't get care in your state, in a neighboring state. Professor Dellinger and Dr. Gray have, detailed some of the areas where this law is just unclear. So, I mean, there's going to be some sort of shakeout period in terms of interpreting it. But I would imagine that many people are going to think that they just don't have access to care. And my concern is that in particular, those with health conditions that might otherwise lead them to seek abortion will hear that they can't have abortion care after 12 weeks. We want to be able to provide compassionate care for people and look holistically and say, what's the best for your health overall? And I think that this will make it more difficult for people to understand that they still may be able to get access to care, that they may still be able to ask their doctors, is this threatening my life to the point that we need to move forward with an abortion? It also is just going to be difficult. When I have trouble understanding what the exact, sequence of care would be, and I've read it a couple times and I know what our current sequence is and I know sort of what they maybe could have been getting at, that means that it's going to be really hard for other people to understand. And so, are people going to show up for care at that first visit and think, oh, well, I'm not getting an abortion today. I went to all this stuff to put my life on hold so that I could come in for this appointment. And now you're not going to give me, I'm not going to be able to get my abortion care. That would frankly make a lot of our patients pretty angry. They sacrifice a lot to be able to get the care that they need. And so it's really frustrating that they are now going to have this other barrier that they have to deal with that is going to have to be very clearly communicated to them. And then that they're, frankly going to have to deal with. So, it's just one of the ways to make care more confusing. And when care is more confusing, that is one other way that it makes it more difficult to access. I don't think, that it's really a misnomer that this bill does anything to protect women or, protect children. This is just an ideological bill about, at least the abortion restriction components is just an ideological bill about limiting access to something that, a minority group of legislators and North Carolinians disagrees with.
Thank you for all of that additional context. And on the subject of misinformation, Dr. Gray, I'd like to come back to you. We have touched on this, but I think it's important to clarify for people. Based on your understanding of this bill, were it to become law, where would that leave the state of telehealth, reproductive medicine, and access to abortion by medication in this state, as you understand it?
So there's already a telehealth ban in our state, so that's not care that we're able to provide as physicians in North Carolina. So the telehealth regulations would require the 72-hour visit in person, the follow-up visit for the medication to be administered in person 72 hours after the counseling was performed. And then there's an additional requirement on top of that for an in-person visit 1 to 2 weeks after the medication is given to ensure completion of care. And so there's a lot of evidence that patients can follow up either over the phone or with a high sensitivity pregnancy test about 5 weeks after taking medication, or follow up if they have any issues or problems. And again, this is not allowing patients to trust themselves or trust their doctors. It's requiring an additional visit in person that may not be necessary. And I think the strategy of this in-person 72-hour regulation is just to limit care of patients traveling from out of state. And I think that it's not increasing the safety of care. If you ask patients if the 72-hour waiting period helped them make their decision, they say no. And we've touched on this already, but there's no other procedure that we do in medicine where you have all these hurdles that you have to go through, and particular types of consent and language that's dictated by the state. It is incredibly insensitive. If I'm caring for someone who has a desired pregnancy, who finds out devastating news about a birth defect, I have to tell that person 72 hours before their care that the father of the baby is liable to pay child support. And that feels horrible. It's forced language that doctors have to say to their patients, that nurses have to say to their patients, that just feels so insensitive. And it really upsets patients. And I would say on a weekly basis, we have patients that are really distraught about what we're forced by the state to tell them. And, legislators are telling our patients, do you really know how to make a good decision for yourself? You need to go sit in the corner for 72 hours and think about this, and then you can come back. But now they're forcing people to come in person. And it's a tragedy to see this play out like this, when we know that it doesn't increase safety. We know that it doesn't improve the care that we provide. And it's really meant to be a roadblock for people.
Answer. Professor Dellinger, I would like to come back to you. You work in the area of privacy. Clearly, this is a privacy issue. But you have written recently that reproductive health is being governed by pre-1970s law now, but with 2020 surveillance capabilities. Should this bill become law in North Carolina, what are some things that people should be aware of as it pertains to the personal health data they have on their phones and how it could potentially be used against them?
Well, it's an important thing to keep in mind. I mean, certainly all of these laws, though it's an abortion law, it obviously affects decisional privacy and your ability to make a decision about your own body. It affects your physical privacy, your bodily integrity. But it does, these laws that interfere with when you can get care necessarily cross over into information privacy issues. So back to the point that I was making earlier about self-managed abortion. If self-managed abortion is illegal and a prosecutor chose to prosecute a person for obtaining abortion drugs, that would involve all kinds of information that individual generates in their everyday life by using their phone, by searching the internet, by using a femtech app and recording the first day of their last period, by purchasing abortion medication online. All of those things could be used as evidence against a person in a prosecution. And even where providers are targeted, women's bodies and women's information will be surveilled as part and parcel of prosecutions of physicians. And of course, providers will be surveilled. Literally, this is what we're talking about. This whole hour is the extensive surveillance that the doctors are subjected to by having to follow all of these rules. Their relationships, their doctor-patient relationships are governed by this web of requirements. So I do think, one important thing in this area to consider is that this is an abortion law. And I feel like many people think, oh, abortion, that's not my issue. I don't care one way or the other. That doesn't affect me. And I just want to point out that anytime you have a law that restricts abortion, it affects every person in the state who needs reproductive care and anybody who cares about any of those individuals, any kind of reproductive care, for pregnancy, for a healthy pregnancy, for any kind of pregnancy, for any kind of reproductive care at all. And states that restrict abortion have higher rates of STDs, they have higher rates of teen pregnancy, they have higher rates of maternal mortality, and all of those things will affect us all as a state. This will disincentivize people from moving here. It will disincentivize people from coming here to train, to become doctors. And we have world-class healthcare and medical facilities here. We want them to stay that way. We want to incentivize people to come to our state, businesses and families. So it's an abortion law, but it has such far-reaching consequences for everyone in our state that we can't just limit our thinking in that way to, it's not my issue. It's frankly everyone's issue.
Thank you, Professor Dellinger, for those comments. And I'd actually like to follow up on that with you, Dr. Swartz, and Dr. Gray. I'd like for you to weigh in on this too. Based on some of the things that Professor Dellinger just said, how will this affect reproductive health care for patients who want to become pregnant and carry a pregnancy to term and have, for want of a better expression, a normal delivery? How will this law impact your ability just to provide care more generally and across the state?
Yeah, I mean, I think the sort of intimidation of providers that is within this law does have ripple effects on all sorts of other care we provide. This law has, these requirements around this false narrative of babies that are born alive after an attempted abortion and criminalization of providers who don't provide resuscitative care. Well, the truth is that doesn't affect abortion providers because that's not something that we do. But it might affect neonatal care for people who wish to carry on a pregnancy or have a pregnancy that has with a baby that has some birth defect or is just sick for some reason, and the parents want to make a compassionate decision about what sort of medical care that baby should have. I don't know whether they will continue to have the same choices around the care of that baby as a result of this law. In terms of other impacts, I think Professor Dellinger articulated really well that I think that this is going to drive talented physicians away from our state, just as it has in other places. OBGYNs are leaving states with restrictive abortion bans, and our trainees aren't wanting to go. OBGYNs are choosing states for residency where they have access to full scope training. So abortion is healthcare, and it is part of the necessary care that we provide. Legislating it just doesn't allow us to care for humans who don't fit into the boxes that legislators want to put them into. So, I think it will affect healthcare for people across the state.
Thank you. And Dr. Gray, a follow-up question for you. We know that when abortion is restricted or outlawed, that the rate of non-clinical abortions increases. What are some of the effects that you would see among patients in society more broadly when that happens? What are some of the risks?
I mean, I think luckily we live in a time where patients do have access to medication abortion, and there's a lot of evidence that self-managed abortion can be safe with medication. It's effective and it has a great safety profile, despite a lot of the misinformation out there that folks might hear. But I do worry that patients who do have an issue or, need follow-up or have some sort of question might feel hindered in seeking care, either going to the emergency room or going to their doctor, because they might be worried that they might be prosecuted. And we've seen instances where patients have had a miscarriage and, there's no test you can do to detect whether or not someone's had a miscarriage or whether they've used a medication for abortion. And so I think there are patients who might be hesitant to seek care in those instances. And so I think it does impact how patients interact with the medical system, how comfortable they feel asking questions or seeking care. Ideally, patients would have access to a knowledgeable healthcare provider who could help guide them through whatever process they're going through. But I worry that this will impact that. I think the other point that Dr. Swartz made, that, trainees are looking at other places for training. As the residency program director here at Duke, we're a top 10 residency program, and we attract some of the best and brightest people every single year. Amazing people to train. And there was some data that came out last week from the AAMC that said for graduating senior medical students in states with a strict ban, there was a 10% decrease in applications in those states. And states with gestational age bans also had a decrease in applications. And so I worry about attracting the best and the brightest to North Carolina. And many of those folks that come and train for residency, they see what a wonderful place North Carolina is to live and work. And, you know, it's a beautiful state to live in. And there are amazing people here. And we want to attract talented people, whether they be OBGYNs or internal medicine physicians, family physicians. And I worry that these bans will impact all of those fields of medicine and who decides to come here and train. And that has downstream effects. So if we're not attracting the best and the brightest, often those people stay in the state after they finish training. You know, 10, 20 years from now, there will be ripple effects.
Absolutely. Thank you, Dr. Gray. We are getting close to time here, but I would like to come to each of the panelists. And Professor Dellinger, we'll start with you with one more question. Is there anything that you feel we haven't covered or anything you would like to reiterate, possibly, especially if there are any legislators who watch this briefing who might be trying to decide exactly how they will vote if the thing comes back for a veto override?
Well, I would just say, I mean, legislating is hard. Public service is hard. And I respect people who spend their lives trying to do that. But this isn't the wheelhouse of legislators. This is the wheelhouse of Dr. Gray, Dr. Schwartz, their colleagues, medical professionals across the state. And it's just not tenable to forge ahead without getting the input of these experts to be able to provide the best reproductive care that we can for all people in North Carolina.
Final points you'd like to make?
You know, I decided to provide abortion care because it's one of the most gratifying types of healthcare I've gotten to provide. Dr. Gray mentioned earlier, and I agree, it's an honor to be able to care for patients, to provide a treatment when they need something that can often be, you know, even as little as 5 to 10 minutes of treatment and can change the trajectory of their life in a positive way. It is life-affirming care and life-saving care, and it's an honor to get to do that. This has been a really rough couple of days, I'll be honest. The bill was introduced quickly. It's just, you know, sort of a surprise. But one of the most uplifting things is that protesters are filling the galleries of the North Carolina legislature right now. So many that they didn't fit in the gallery of the House yesterday. There were hundreds of people who showed up for a rally on less than a day's notice. People care about this. The North Carolina legislature is working to pass something that is not consistent with popular opinion. And for that reason, I believe we'll come back. You know, I think I am really inspired by the people young and old who showed up on short notice to make their voice heard. And so even if this is a loss and a loss of care, we'll figure it out. We'll continue to provide care here as best we can. We'll help our patients get the care that they need. And, you know, hopefully in the next legislative session, we'll have a wave of Democrats who come back and, or legislators who support abortion access who come back and reverse this law.
Thank you, Dr. Schwartz, for those closing remarks. And Dr. Gray, anything you would like to add?
You know, I think as a native North Carolinian, I love my state. I'm very proud to live here and proud to care for the patients of our state. I agree with Dr. Schwartz that this last couple of days has been challenging because our patients trust us and they trust us to provide them with evidence-based medicine and care and compassion, and we will continue to do that within what the law allows. And I am hopeful that things will change in a positive way so that people can get the care that they need. I think people should be worried, though. And I think people should be reaching out to their representatives to talk to them about how they feel about this. This is one stepping stone to a 6-week ban, to a complete ban. And I do not want that for the people of my state.
Absolutely. Thank you, Dr. Gray. We will call it there. Thank you very much to our panelists, Beverly Gray, Jonas Swartz, and Jolynn Dellinger, for sharing your expertise and opinions with us today. If you'd like to be notified about upcoming briefings, please email dukenews@duke.edu. Please, in the meantime, please stay well, stay informed, and stay calm if you can. Thank you very much, and have